Alicia Gallegos reporting for Frontline Medical News. We're here today at the Society of Hospital Medicine annual meeting, and we're chatting with Dr. Dan Hansen about his session on innovative hospital staffing models. Thank you for being here with us today. My first question for you is if you can talk a little bit about your hospital system and what were some of the problems that you faced that you were looking to address.
Our primary issue is that patients were being discharged in a way that delayed care for other patients. You know, hospital beds are they're hard to come by in the middle of the day, and so we wanted to find a way to actually make our hospital more efficient, so fewer people were waiting in the emergency department to get hospital beds. This meant that we needed to find new innovations to try to restaff our workflow so that we could get to these people earlier, get them out of the hospital at a time that was appropriate for them instead of keeping them waiting.
And Doctor, can you tell us a little bit about what were some of the primary strategies that you decided to employ to address some of these issues?
A large part of our hospital population are internal medicine patients as opposed to surgical patients or other patients. And we knew that a large number of those patients were cared for by house staff or physicians who were training. We looked directly at the workflow of the hospital trainee, which in our institution is the medical intern. We followed them, watched them, saw their work, and saw that we were creating a lot of inefficiencies in their day. So we reorganized their day in a way that made sense to them. Instead of centering the day around the physician attending or the supervising resident, we centered it around the patient and the intern. We found efficiencies in their day and helped them be more efficient and helped patients leave the hospital when they were ready rather than keeping them waiting.
Absolutely. And can you talk about some of the benefits, maybe the broader benefits that you've seen since employing some of these strategies?
Yeah, so the hospital intern taught us that if we focus on taking care of one patient at a time, rather than asking them to do multitasking, trying to take care of too many people at the same time, answering pages, trying to finish progress notes late in the day when they should be done right when they're seeing the patient. What that taught us is that if we found a way for the other hospitals who work in the organization who do not work with interns, we found a way to staff them, provide them with medical assistance so that they could actually work in the same manner, that we also improved hospital workflow for them.
Excellent. And Doctor, any guidance or advice you might have for other hospitalists or hospitals out there who are looking to address some of these same problems?
There are a lot of different ways to improve your workflow efficiency and improve the quality of the day for your patients. And we don't necessarily have the only answer. There are hundreds of answers out there. The key thing is that you focus on the patient and the people who are caring for the patient or who are closest to the patient. Follow their work, watch what they do. They'll teach you where the efficiencies can be gained. And in that way, if you do that, you'll find your own way. You'll find and stick to those principles. You'll find what works best in your organization.
I'm Alicia Gallegos reporting for Frontline Medical News. We're here today at the Society of Hospital Medicine annual meeting, and we're chatting here today with Dr. John Nelson about his recent session on innovative hospital staffing models. Thank you so much for joining us today, Doctor. And my first question is, can you tell me a little bit about your hospital and some of the problems or issues that you were looking to address?
So I'm at a hospital in the metro Seattle area. It's Overlake Hospital. It's 330 licensed beds, and we have it's a non-academic setting and a hospitalist group that's about 19 people.
Excellent. And one of the things you spoke about, which I'm really interested in, is the slam and dwindle. Can you talk a little bit about that? What is that, and why is it different?
Sure. So slam and dwindle is a term that colleague Eric Howell said for the first time, and I thought it really describes very well the system of assigning patients that we use where I practice and a handful of other places do too. And I think it's an idea that a lot of other groups might want to consider adopting. Basically, the idea is that A doctor is not responsible for taking on the care of any new patients on their last day on service. So if I'm not returning to work tomorrow, I don't take on the care of any new patients today. The benefit is I have fewer patients to hand off to someone else, and fewer handoffs equals better continuity. And in some ways, I think continuity is king. That's one of the most important variables or metrics we can manage in our hospitalist groups. So that's what Slam and Dwindle is.
Okay, and can you tell us a little bit about any costs with this type of a system, any disadvantages or other things that might come up?
The advantages are there's a little bit of complexity in getting it to work. So if you're going to exempt a doctor from taking on any new patients the last day they work, you can only have one doctor who is working their last day at a time. So if you're a group like many that has all your hospitalists change on the same day, say 5 hospitalists working on Tuesday, all rotate off to be replaced by 5 different hospitalists on Wednesday, then you couldn't exempt all 5 of them, obviously, from admissions on their last day. There'd be nobody to see the patients. So if you instead change to a system where there is only one doctor rotating off each day and the others are working and taking new patients, then it's easy to exempt that one doctor from admissions on the last day. It also builds in additional time for that doctor to more effectively tee up the patients for the colleague who takes over the next day. So that can include doing all the discharge preparations, writing interim summaries, and so forth for the doctor who takes over the following day. It also means that if I don't admit anybody or take on new patients on my last day, I turn over a list of patients that is much smaller than the typical number of patients I see day to day. So that's a benefit to the doctor coming on tomorrow. That doctor faces a smaller list of patients to get to know from me.
Okay. What advice or guidance would you have for other hospitalists or hospitals? Does this model work in other type of environments, and anything you would like to share as far as guidance?
So it can work anywhere. The Slam and Dwindle idea of sort of front-loading admissions or new patients to the doctor's first few days they're on service and having them take on fewer or none on the last day they're on service, that can work in any setting. But it requires a schedule that would accommodate that system. And for most groups, the biggest hurdle will be what I just mentioned, changing the schedule so that only one doctor rotates off at a time rather than the whole group rotating off.